Hello everyone and welcome to our second module on pneumonia. So in this video, I'm going to go through some specific pathogens that can cause pneumonia. All of these infectious pathogens I talk about in much greater detail in the infectious disease section, but here I'll just review some key facts about each of them and talk about the type of pneumonia clinical course they typically lead to. So we'll start by talking about Legionella. So this bacteria was first identified at the American Legion Convention. That's why it's called Legionella. And patients develop infection from inhaling aerosolized bacteria. So this is not an airborne infection. What happens is the bacteria can grow in water and then become aerosolized in small droplets of water, and that's how it gets in your lungs. So if you understand this, then you can understand how outbreaks can occur at hotels with contaminated water. And that's how the initial infection was described at the American Legion Convention. You can also get Legionella outbreaks in patients in nursing homes. You can have nosocomial pneumonia, that's what we call it when you get pneumonia in a nursing home, and it can come from Legionella if the water's been contaminated. So Legionella is one of the atypical bacteria that usually causes pneumonia with a less severe clinical course. So when patients first develop Legionella infection, they usually have mild pneumonia symptoms. So they could have fever, a slightly productive cough, but they're not as sick as someone might be with a lobar strep pneumonia infection. Now, if left untreated, this can progress to severe pneumonia, but it's the initial symptoms that are usually mild. And then there are two special things to know about Legionella, particularly when you're answering board questions, because these are big clues to the infection. The first one is that patients who have Legionella pneumonia often have concomitant GI symptoms. So they can have watery diarrhea, nausea, vomiting, or abdominal pain. So a patient who has fever and a cough and also GI symptoms should make you think of Legionella. And then second, hyponatremia, meaning a low serum sodium concentration, is very common in Legionella pneumonia. Now this can happen with any pneumonia, but it's more common in Legionella. Pneumonia or lung infections often lead to an increase in ADH release from the pituitary gland. The mechanism of this is poorly understood, but basically any pneumonia can cause SIADH leading to hyponatremia, but this is especially common in patients who have Legionella pneumonia. The diagnosis of Legionella infection is made in a special way. So the first thing to know is that Legionella has special culture requirements. It doesn't gram stain very well. You can grow the bacteria on a special type of agar called buffered charcoal yeast agar. This is an agar like what's shown on the slide right here. It contains iron and cysteine for growth. It's also supplemented with antibiotics to keep other types of bacteria besides Legionella from growing, and also with silver dyes. So the antibiotics or the antimicrobials prevent overgrowth from competing organisms, and the silver dyes give a distinct color to Legionella. So this is one way you can make the diagnosis, although this isn't typically done. Instead, what we usually do to make the diagnosis is a urinary antigen test. This is a rapid test. It's available in minutes. It doesn't test for all Legionella types, but if this test is positive and the patient has typical signs and symptoms, that's often how the diagnosis is made. So the classic case of Legionella pneumonia to be familiar with is, first of all, a patient with a mild pneumonia. So they might have a mild cough, but they shouldn't have severe shortness of breath. They'll have some GI symptoms like watery diarrhea. Their sodium will be low if lab testing is done, and this can lead to confusion, especially in an older patient. And then if you do a gram stain of a sputum sample, it will be negative, and that's because Legionella doesn't gram stain well. So the diagnosis is made with the urinary antigen test in most cases. And treatments are with antibiotics that cover atypical bacteria. This includes fluoroquinolones like levofloxacin and also azithromycin. Besides Legionella pneumonia, Legionella can also cause a syndrome called Pontiac fever. This is a milder form of Legionella infection. It follows exposure to the bacteria. Patients develop fever, malaise, chills, fatigue, and headache. All these are very nonspecific findings in someone who has an infection. But importantly, they have no respiratory complaints, and the chest radiograph is usually normal. So when there's a Legionella outbreak going on, for example, in a nursing home, many patients will develop Legionella pneumonia, but some patients will develop these things here. Those patients have Pontiac fever. And it's important to know this because this is a self-limited condition. It usually doesn't require any treatment. Usually no diagnostic testing is done. You just have to know that when there's a Legionella outbreak and many patients are being exposed, some of them will develop this milder infection called Pontiac fever. Okay, let's talk about mycoplasma pneumonia. This is another atypical pneumonia. So it causes interstitial infiltrates on chest x-ray like what is shown here. I discussed these in other videos. Mycoplasma also does not gram stain well. It has no cell wall, so it can't take up the gram stain. And like Legionella, it classically causes outbreaks, but more often these occur in young adults. So for example, In a college dorm, mycoplasma pneumonia will run through all the people who live there, or military recruits who live in a barracks together. Mycoplasma is famous for having a chest x-ray that looks worse than the symptoms. So for example, patient will have a very mild cough and not look very sick, but you'll do a chest x-ray and see a widespread diffused interstitial infiltrate that looks worse than the patient's clinical course. There are a number of potential complications of mycoplasma pneumonia, but some that are worth knowing about, especially for step 1, are first of all, the mycoplasma infection can lead to autoimmune hemolytic anemia. So it can cause the generation of IgM antibodies that bind to red cell antigens, and this causes a form of hemolytic anemia called cold autoimmune hemolytic anemia. And I talk about this in detail in the hematology section. You can also see mucocutaneous problems in patients who have mycoplasma pneumonia. Sometimes this is just a rash, but if it's severe, it can lead to the Stevens-Johnson syndrome, which I talk about in the dermatology videos. Let's talk about the influenza virus. This also causes an atypical pneumonia, so typically a milder form of pneumonia with those interstitial infiltrates seen on chest x-ray. This can be caused by either the influenza A or B viruses, and it leads to, first of all, nonspecific symptoms of infection, things like fever, headache, myalgia, malaise. And then there usually is also evidence of respiratory tract infection, so patients will have a non-productive cough, they can have a sore throat, they can have runny nose. And because this is an atypical pneumonia, it usually has a milder clinical course, except for the fact that its major complication is a secondary bacterial pneumonia. This is how patients often die from influenza virus infection. When the influenza virus outbreak occurred in the United States in the early 1900s, most people didn't die of infection with the virus. They died of secondary infection with a bacteria. Some of the bacteria that can cause secondary pneumonia are Strep pneumoniae, Staph aureus, H. influenzae. I talk about all these things in the infectious disease section. The way this will present clinically is the patient will initially have mild symptoms and seem to be doing better or improving, and then suddenly the symptoms will get much, much worse. That usually indicates a secondary bacterial pneumonia. And as I said, this is the cause of death in patients who have influenza virus infection. Okay, let's talk about infection with SARS or COVID-19. This virus is famous for the worldwide pandemic it caused. It leads to a bilateral interstitial pneumonia. So the typical pattern on chest x-ray is that of an interstitial pneumonia. And in terms of symptoms, as you may know from the pandemic, the symptoms are widely varying. Some patients are entirely asymptomatic and some develop severe forms of pneumonia. Some of the things you can see are listed here. So this includes fever, shortness of breath, confusion, and cough. Many patients have chest pain and tightness, and severe cases lead to cyanosis. Primary infection can be treated with the antiviral agent remdesivir, which I talk about in the infectious disease section, and patients can develop a superinfection on top of the viral infection with a bacterial cause of pneumonia. And a serious complication that we worry about in COVID-19 infection is ARDS, which I talk about in the first pneumonia video. This is what led many patients during the pandemic to require mechanical ventilation in the ICU, and sometimes even ECMO. ECMO is the heart-lung machine. It circulates the blood and oxygenates it for patients whose respiratory status is extremely poor. Let's talk about cytomegalovirus, which is a very rare cause of pneumonia. It requires immunocompromise to cause pneumonia, so it's a classic cause of pneumonia in patients who had a solid organ transplant, like a liver or a kidney transplant, and they're taking immunosuppressive drugs. The classic pathfinding of a CMV infection is the presence of so-called owl eye intranuclear inclusions. This is a picture of one on the slide right here. It's a classic finding in CMV infected cells. Basically, it's a basophilic or deep purple inclusion in the nucleus of the cell. It's very large. It takes up at least half the diameter of the cell, just like you can see here. And usually there's some white clearing around the inclusion, which you can also see in this example here. So get familiar with this. Don't confuse it with a Reed-Sternberg cell in lymphoma. That looks different. I talk about that in other videos. You see this type of thing in a board question, they're talking about cytomegalovirus infection. RSV is the respiratory syncytial virus. This is a viral respiratory infection that occurs in infants. It usually leads to seasonal outbreaks during the wintertime from November to April, and it's the most common cause of lower respiratory tract infection in children. If you do a pediatrics rotation during the winter, you will see children hospitalized with RSV very commonly. It can lead to bronchiolitis, which means inflammation of the bronchioles, also to pneumonia, and in rare cases, acute respiratory tract infection. It often starts with symptoms of an upper airway infection, so children who have this will have a runny nose for a few days, and then after that, they'll develop lower respiratory tract infections, in particular wheezing. This is a classic finding And that's because the virus causes bronchiolitis or inflammation of the bronchioles. It narrows those bronchioles, and that causes wheezes to develop when the child breathes. So the classic case of RSV infection is going to be a young child, often less than 2 years of age. They initially have a fever and runny nose, and then a few days later, they start to cough and develop wheezing. And this is such a common infection in young children that it's often diagnosed clinically without any specific diagnostic testing done to identify the RSV virus. There are a couple of treatments for RSV that you should be familiar with, so let's review those now. The first one is an antiviral agent called ribavirin, which I talk about in videos in the infectious disease section. But what this drug does is it inhibits synthesis of guanine nucleotides, and viruses like RSV need to make lots of nucleotides so that they can copy their DNA and RNA, and so this drug inhibits that process. And then there's a monoclonal antibody that can be used for prevention in children who are at high risk. That drug is called palivizumab. It's a monoclonal antibody against the F protein. So the F protein is something synthesized by RSV viral particles, and it allows them to fuse with respiratory epithelial cells and get inside the cell. So this antibody binds to the F protein and blocks its ability to link with host cells like the cells in our lungs, and therefore to enter those cells. So this is only used in children who are thought to be at very high risk of RSV. Usually it's preterm infants. Sometimes it's children with advanced forms of congenital heart disease. Aspiration pneumonia is a form of pneumonia that occurs when patients aspirate microorganisms. So to aspirate means to inhale fluid or bacteria. And the way this often happens is when patients vomit or they can't protect their airway, so they swallow lots of oral secretions. And so when patients aspirate, bacteria from the oral cavity and the nasopharynx find their way into the lungs. So who is this likely to happen in? Well, it's going to be people that aren't able to protect their airway, meaning they can't cough to keep themselves from inhaling substances that are in their mouth. So this includes patients who have reduced consciousness, for example, patients under anesthesia. This is why we ask patients to fast before surgery, because we don't want their belly to be full of food and fluid that they might inhale during surgery when they're unconscious. It can also happen to patients who have seizures, patients who consume lots of alcohol, or patients who have dysphagia and difficulty swallowing because of some type of neuromuscular problem. But in all these cases, the idea is that the patient can't cough normally, and therefore things that get in the back of their throat, whether it be stomach contents or just secretions from the mouth, can be inhaled into the lungs. So some of the classic patients where you'll see this in actual practice in the hospital are debilitated nursing home patients who can't protect their airway, patients who consume lots of alcohol and therefore don't have sufficient level of consciousness to protect their airway. Some of the bacteria involved in aspiration pneumonia are shown on this slide. Probably the most important group to be familiar with are the anaerobic bacteria that are found in the mouth. All of these bugs here are anaerobic bacteria found in the mouth, and they're often part of aspiration pneumonia. And this is one of the reasons why treatment with antibiotics has to have good coverage of anaerobes. Beyond this, there are a couple of strep species that are often involved. This includes strep pneumoniae and strep viridans. And then when patients are hospitalized, sometimes more dangerous bacteria are involved in aspiration pneumonia. This can include gram-negative rods from the GI tract like Klebsiella and also Staph aureus. So the first-line therapy for patients who aren't hospitalized, who aren't at risk for one of these more severe infections, is usually with amoxicillin clavulanate. This is a beta-lactam drug, amoxicillin, along with a beta-lactamase inhibitor, clavulanate. Now, if patients are allergic to penicillin and they can't take amoxicillin, then there are a couple of backup options. One of those are certain quinolones, like moxifloxacin is often used. And then clindamycin is a drug that used to be commonly used for aspiration pneumonia. Now it's become a second-line agent because it carries a high risk of C. difficile infection, but it's still used sometimes in patients who have a pen allergy and who have aspiration pneumonia. Let's talk a little bit about Klebsiella pneumonia. I talk about this in more detail in the infectious disease section. So Klebsiella can cause a lobar pneumonia, and it often develops after aspiration, as we just talked about. And this bacteria is famous for causing lots of inflammation and necrosis, and as a result, it creates sputum that is very thick and filled with mucus, meaning mucoid, and often blood-tinged. And it's said to look like currant jelly. So currant is a type of fruit, and it has a look like blood-tinged sputum that you see in Klebsiella pneumonia. And that's why this is sort of the buzzword for the sputum that a patient with a Klebsiella infection will produce. Okay, any pulmonary infection can potentially lead to development of a lung abscess. A lung abscess is a well-contained area within the lung that contains fluid and air. So basically, inflammation creates a wall around an area of infection, and you get some fluid and some pus down at the bottom being pulled down by gravity. And at the top, you have air because air was inside the lungs when this area was walled off. This means that on imaging, what you'll see is an air fluid level. And this slide here shows a chest x-ray with an example of an air fluid level. So if we look at the AP image on the left, this is the abscess right here. You can see it's white at the bottom, that's the fluid, and you can see it's dark at the top, that's the air. So this is a walled off area with an air fluid level, that's a lung abscess. And these are relatively easy to see on chest x-ray, so this is something you should be able to recognize as a medical student. You can also see one over on the right side here. I'm circling it with my pen. You can see the white stuff at the bottom, the dark stuff at the top. Usually a lung abscess is a consequence of aspiration. That's how these typically develop. But sometimes it can also happen if there's bronchial obstruction from cancer. So in this case, secretions aren't being cleared out of the bronchi. They can build up behind the bronchi, and that can lead to development of an abscess. Since lung abscesses often come from aspiration, many of the bacteria involved in lung abscesses are similar to the bacteria we talked about a few slides ago for aspiration pneumonia. So first of all, what you predominantly find inside lung abscesses are mouth anaerobes. That includes all these bacteria here, which we talked about a few slides ago related to aspiration pneumonia. Also, some of the other bacteria that we said that can sometimes be involved in aspiration pneumonia. This includes things like Staph aureus and gram-negatives like Klebsiella. The treatment is usually with broad-spectrum antibiotics. Some of this has more to do with the fact that these drugs can penetrate the abscess very well, as opposed to which specific bacteria they cover. But ampicillin sulbactam, which is a broad-spectrum antibiotic combination, is sometimes used. So are carbapenems. Occasionally moxifloxacin, the quinolone is used. And then the old-school treatment that's rarely used anymore is clindamycin. This has good coverage of anaerobes, but in modern practice, it's not used as much anymore because it often has treatment failures due to resistance. And then the last infection I'll talk about in this video is Pneumocystis jirovecii pneumonia. This used to be called PCP pneumonia. PCP stood for Pneumocystis carinii pneumonia, but it was renamed to Pneumocystis jirovecii a number of years ago. This is not a bacterial infection, it's a fungal infection of the lungs, and it causes diffuse interstitial pneumonia like what's shown on this x-ray here. This infection only develops with immunocompromise. It's a classic complication of HIV. In fact, when HIV first developed in the 1980s, the way that patients presented was with this form of pneumonia. And in fact, PJP is considered an AIDS-defining illness. If patients have this, by definition, they have the acquired immunodeficiency syndrome. And I talk about HIV in great detail in videos in the infectious disease section. The way this infection is acquired is that the yeast is inhaled and it travels to the lungs, and that leads to infection. If your immune system is intact, this will usually be handled with no clinical consequences. It's only if you have advanced HIV or some other form of immunocompromise that you can get sick from inhaling this yeast. PJP is diagnosed by microscopy, so you have to visualize the yeast like what's shown on the slide here, either from a sputum sample or a sample from a bronchoalveolar lavage. You have to use special stains. You can't culture this fungus. The special stain that's often used is a silver stain. That's what's shown here. And it lets you see all the little yeast in these little circled dark things like you see on this slide. Some of the treatments for PJP pneumonia are shown here. I discuss all these drugs in detail in the infectious disease section. The first line treatment is Bactrim, which is TMP SMX, but this is a sulfa antibiotic, so some patients have allergic reactions, and then all these alternatives can be used. And then in patients who have advanced immunocompromise, we give them prophylaxis. So in patients with HIV, if their CD4 count is less than 200, which is very low, they are given TMP SMX prophylactically to try and prevent this infection. If the patient can't tolerate TMP SMX or has an allergic reaction to the sulfa moiety, then you can also use dapsone and atovaquone. And that concludes our second module on pneumonia.